And I think we're live now.
Okay, let me just, the attendees are starting to load. Okay, I think people will trickle in, but I think we can start. And I'll just give a little introduction if I might. I'd like to welcome everyone. My name is Jillian Lashota, and I'm the founder and the Chief Executive Officer of the iRise Above Foundation. For those of you who have not heard of us, I would like to take this opportunity to share with you a little bit about who we are, with the hopes that you too will want to join our movement and perhaps some of our program offerings. You might find something that resonates with you if you check out our website. We are a nonprofit organization that strives for outstanding quality of life, empowerment, and inspirational support for young women diagnosed with breast cancer. We support women of all ages. We believe that every woman deserves to live a great story and not be defined by breast cancer. As a young woman diagnosed with breast cancer, you face a unique set of challenges that your older counterparts do not. Our mission with the foundation is to surround young women with targeted, age-appropriate, and connected health and wellness resources and tools to enable them to rise above the residual effects of breast cancer, to find healing, and to live well. Part of living well after breast cancer is integrating in one's life physical fitness, a healthy diet, a healthy mindset, and a strong community to surround you. Here to talk to us today about what you need to know, weight, nutrition, and exercise in young women after breast cancer is Dr. Jenni Sheng. Dr. Sheng is an oncologist and assistant professor of oncology at Johns Hopkins University School of Medicine. Her areas of clinical expertise include internal medicine and oncology, caring for men and women with cancer. She addresses living with, through, and beyond cancer. As she primarily treats patients with breast cancer, she discusses the best treatment options, manages symptoms from cancer and treatment-related side effects, and focuses on psychosocial aspects of care. In keeping with comprehensive survivorship care, she plans surveillance and screenings and encourages health promotion. Example, diet, exercise, and interpersonal relationships and care coordination. So without further ado, please welcome Dr. Jenni Sheng. Thank you for coming.
Of course, thanks so much for that warm introduction, Jillian. This is a beautiful mission, and I'm so happy to share some of the insights that we have. So I'm going to share my screen with everyone. So I've titled this talk Surviving and Thriving because it's not just about living longer, but living well. And there are three main areas that I'd like to focus on today, which are nutrition, exercise, and weight. So I'll probably spend a third of the time talking about recommendations that we have for all individuals who've had breast cancer, and that would address nutrition, exercise, and sleep. And these are evidence-based recommendations. And then I'm going to jump into why weight is so important and why there's so much focus on it, especially the last several years. And I'm going to talk briefly about some cancer and non-cancer outcomes. And lastly, I'm going to go over some recommendations for weight loss because it is certainly a struggle for many who are trying to tackle that. So foremost, let's jump into nutrition. So over a period of time, we've really learned about the components of diet that are harmful as well as beneficial. And some of these may seem intuitive, but we have recommended formally in our National Comprehensive Cancer guidelines to limit high calorie foods and low nutrient foods. So things that we think fall into that group are soft drinks, really sugary desserts, and fried foods. We formally made a statement about red meat and that we advise less than 18 ounces a week, as well as processed meats. When possible, we try to limit the amount of refined sugar. And so when I talk to people about the types of sugars to take, I talk about stevia, a lot of the natural sugars that do exist. And alcohol, we really don't recommend drinking more than a drink a day. And what we do encourage is we do actually support an at least a plant-based diet in over 50% of one's daily consumption. And so if you look at this graph here on this right-hand side, you'll see that we have this circle composition that helps us to visualize how to break down everything that we take in a day. So for instance, we say that fruits may comprise about 20% of that, and vegetables should be comprising 30% of that. And that whole grains should also be about 20%, and that lean protein should also be filling out that last quarter. And we do encourage low calorie foods and really high nutrient foods. So examples of that are low starch vegetables, broth-based soups, fresh fruit for dessert, water, unsweetened tea, and black coffee. And I'd like to just share some of the studies that have been done really looking at nutrition in people who've had breast cancer. So this was called the WIN study. It's the Women's Intervention Nutrition Study. And what they did is they followed women who had early stage breast cancer that received really standard of care breast cancer management. And they randomized women to two groups, a group that had a dietary intervention and a group that basically was a control group. They kind of ate kind of as per usual. And in this dietary intervention, they had lower fat consumption. They followed more of a Mediterranean diet. And what we found is there was actually a 24% lower risk of relapse in the group that was in this dietary intervention. So it started to raise a lot of really interesting questions. And this was published, about a decade and a half. But since then, there's been a tremendous amount of research in the realm of nutrition. Something of interest in this study is that body weight was actually not an endpoint of this study, but there was this small but significant weight difference between these two groups, about 6 pounds. And so that's where we started to think, well, maybe weight is something that is important that needs to be addressed. And I will come back to that a little bit later in the talk. Next, I'd like to move on to exercise and what our formal recommendations are with the National Comprehensive Cancer Network guidelines. So we do recommend at least 150 to 300 minutes of moderate intensity aerobic activity weekly, or 75 minutes of vigorous activity. We also recommend 2 to 3 days of muscle strengthening activities and stretching major muscle groups at least 2 days a week. So that probably sounds very overwhelming, and it's something that most individuals probably are striving to achieve. And so when we start out, I often will prescribe a very simple prescription for exercise. So I always address any possible barriers before that. So sometimes that can be pain, that can be access to a gym, especially when you think about COVID the past year and what is available to people, and really thinking about some short-term goals and some long-term goals. So everyone is essentially at a different fitness level, but we can start off with really a script as simple as, exercising 1 to 3 days a week, light or moderate activity, and choosing an aerobic activity like walking when the weather's nice like it is now, and doing 20 minutes at a time, and really bumping that up over the course of time. And there are various examples of physical activity. So a lot of this is subjective and it's going to be variable. So we have light, moderate, and vigorous activity. Vigorous being, you can really only say a few words while you're doing that particular exercise. And light, really there's no change in your breathing as you're doing that particular activity. This will be different, right? And as your fitness improves, something that might have been moderate to vigorous might become something that you consider light activity. So, oftentimes we'll say that light activity typically is light housework, slow walking, sometimes childcare can fall into that, but sometimes it can fall into moderate or vigorous, certainly. And then more classically, when we think about vigorous exercise, we think about walking uphill. We think about race walking or fast-paced walking, playing tennis, doing some more high-intensity yoga or some sort of fast dancing or biking, or even heavy gardening. Now, sometimes after treatment, especially if you've had chemotherapy and or surgery or other types of therapy, you can have some sequelae of therapy, and those sequelae of therapy can make certain exercises really challenging to do. So it's important to individualize that and cater to a type of exercise that's really going to be conducive to sustainability. So for instance, for individuals who have significant neuropathy, which is kind of this tingling or pain in their fingers and toes, we recommend stationary biking as opposed to outdoor biking. Of course, this depends on the extent of neuropathy. Some people have significant issues with balance with their neuropathy, and sometimes using water aerobics may be preferable to doing something on pavement. Wearing padded gloves can occasionally be helpful as well, and doing a lot of balance training to support the other muscles and ligaments. Additionally, we tell people to be cautious of lymphedema. So typically this swelling of a limb occurs within the first 18 months after, let's say, surgery or therapy, but more recent literature shows that lymphedema can actually occur at any time point. So it can occur at 2 years or 3 years, etc. And so if you already have lymphedema, it's really important that at least when you're first working out and trying to define what your exercise regimen is, that you work with a trained personnel, and that if you do have a compression sleeve, that you use that consistently. Additionally, if you start to notice the circumference or the total distance around your arm start to slowly creep up or it feels tight, you really need to report that to your physician so that they can make sure that you are maximizing your safety measures when you're doing exercise. Additionally, we've learned that resistance training is really important. So really building healthy muscle mass. And so we focus on multi-joint exercises, all the major muscle groups, and always large muscles first. So that's your legs, your back, and your chest. And the ideal number of repetitions to do to really focus on that goal is to allow for 10 to 15 repetitions. So for example, if you're thinking about a type of prescription for resistance training, I'll say, well, let's start with just 2 or 3 times a week resistance sessions. I usually do recommend a break at least every other day, because your muscles get tired and they also need to rest, and that each set should have about 10 to 15 repetitions per set. And you can really consider increasing the weight in that set when those 3 sets of 10 to 15 are really considerably easier. And of course, take your break in between sets. If you can blow through each of these, then your weight is probably too light. And lastly, I'm just going to touch on sleep. We've had increased research that shows that sleep is just as important as nutrition and exercise. And it's something that a lot of us can struggle with for different reasons. So in terms of strategies to really help with sleep hygiene, we recommend maintaining a regular bedtime and awake time, and trying to actually avoid moderate to strenuous exercise, heavy meals, fluids, alcohol within 3 hours of bedtime. It's really ideal to actually increase light exposure during the day. And if you're someone who, for instance, during the past year has been indoors significantly, then it's good to go outside. It's good to take a break. It's good to have even lights in the house that kind of mimic daytime. We also recommend reducing light exposure within a few hours of bedtime, and that includes cell phones, which can be challenging nowadays. So in addition to that, we recommend avoiding caffeine for at least 4 hours before bedtime, and really sleeping in a really cool temperature in the 60s is ideal. You should not be sleeping in a really warm room. And if you are struggling with falling asleep, do not look at the clock. It will probably provide further challenges with trying to fall asleep. And if you do nap during the daytime, it appears that the ideal amount of time is actually less than 30 minutes, so as to not impair sleep later at night. And of course, if this is a recurrent issue, you've done a lot of the sleep hygiene approaches, talk to your physician about it, because you could have a formal diagnosis of insomnia that might require further evaluation and therapies. You may need to see a sleep specialist. And besides insomnia in and of itself, there are other medical conditions that can cause people to struggle with sleep. So we think about restless leg syndrome, we think about sleep apnea, et cetera. And it really requires more formal evaluation to determine that. And there are other therapies for those types of conditions, whether it's medications like pharmacotherapy or if it's cognitive behavioral therapy. So I'm just going to take a quick little pause, because I just provided a wealth of information about our guidelines for breast cancer patients. And I know that we have an open chat right now. So if you do have any questions, feel free to type them in. Just wanted to give people an opportunity to ask them instead of waiting for the very end of the talk. And none?
No current questions. Oh, I have a question. Yes.
Sure.
Okay. Does resistance training include weights?
Yes, resistance training typically includes weight, but you can also use body weight for some of those exercises. So especially with COVID, most people would say that they don't have access to a gym. And the beauty of a gym is you've got the 1, 2, 3, 5, 10, 15 pound weights. But at home, a lot of us don't have that. We're not buying a whole weight set. And so there are exercises that you can do with your own body weight without any type of formal arm weight or kettlebell or anything like that. And I will say that I have become a fan of recommending YouTube videos, especially when people are doing them at home. And it's as simple as, you can type in resistance training, no weights, free weights, and you'll have probably tens, almost 100 videos that will pop up. So.
Okay, I would just like to put a plug in for those who are interested too. I know there's a lot of people online now as part of this. iRise Above has a wellness training program, which is 12 weeks online, which integrates physical fitness, nutrition, healthy mindset, and community. And so we have personal trainers that work with all of the women. And also on our iRise Above YouTube channel, we have some yoga videos that are available to our community for free. So there's a few more questions here. A question is, I've heard vegan diets help reduce recurrence. Is this true?
Okay, certainly a tricky question. So I will say that as of right now, when we look at the bulk of evidence-based guidelines, we're not recommending any other diet aside from the one that I've already mentioned in terms of something that mimics more of a Mediterranean diet. We do have a lot of studies that are looking at vegan diet, intermittent fasting, ketogenic diet, and I think that there's some really interesting questions that can be answered with those particular strategies, but I can't formally recommend any of those just yet. So something that I think is on the horizon, and I think as studies complete and are able to share their data in terms of how that diet may impact, let's say, a cancer outcome or quality of life or physical function or weight, that will really elucidate what we can recommend to patients more broadly.
Just keeping on the questions related to nutrition. This is a good question that we often talk about in our training program. There's a number of us that are plant-based. So what type of protein do you recommend for women following a plant-based diet?
So I'm a huge fan of lentils and beans, as always, for sources of protein. I will say that I do recommend soy, and I know that there's been some back and forth because there are things called phytoestrogens that can exist in certain foods that are consumed. And for a long time, people were told, well, don't have any soy, don't have any tofu, I have to give this up. And when we look at the literature, broadly, it seems like having, a serving a day is not considered or associated with a higher risk of a breast cancer event. And so I still do encourage that. I think that there is some literature that, looks at levels of estrogen, specifically estradiol in the body, and whether or not that's elevated if you consume certain foods that have higher phytoestrogens. But I think as of right now, we're not seeing a contraindication for that. So those are probably the two main groups that I really recommend. Yeah.
Okay, great. Another question, in terms of nutrition, there is so much information out there. I need calcium for my osteoporosis. Would you recommend dairy? Some say no dairy. What is your opinion?
So this is a tricky question. oftentimes I will ask more questions in trying to figure this out for each particular patient. So my first question will be, are you premenopausal or are you postmenopausal? Because there is certainly a difference in terms of the daily intake that's recommended and how much most people get in their diet. We know that as women age, and especially when they're postmenopausal, whether that was naturally with aging or whether we induced it as breast medical oncologists, there is greater amount of bone loss over time, and that most of those patients would benefit from daily calcium. It will also matter whether or not your medical oncologist has placed you on endocrine therapy, and certain endocrine therapy can accelerate bone loss as well, and that can impact the total amount of calcium that is recommended. So I think this is a really great question, and I would actually ask you to direct it to your breast medical oncologist and help them explain to you why the recommendation is what it is, and really think about your particular features, whether it's your menopausal status, your age, your last DEXA scan. There's a lot that can be incorporated into that individual recommendation.
Great. And so there's one more question here. There's a number of questions on whether or not this this presentation will be shared. I assume it's okay to share after this. Okay.
Absolutely.
And then there's a question regarding lymphedema. Any workouts that you recommend to improve lymphedema?
Yes, certainly. So there are actually quite a few YouTube videos that focus on exercises for lymphedema. Depending on where you get treated, and I think that at both academic and community sites, there are actually physical therapists that you can be referred to for just evaluation of lymphedema, where they can even teach you the exercises, because sometimes it can be really challenging to watch the video and ensure that you're doing it properly and not straining yourself or injuring from poor form. So I would recommend, probably, you certainly can look up the YouTube videos, like you can literally type in lymphedema exercises, and you'll see the videos that are watched the most. But I also would recommend, if you're comfortable with an in-person evaluation, getting a referral to physical therapy for that.
That's great. That's the end of the questions for this segment.
Okay, great. So we're about 1/3 of the way through, and I'm going to now jump into why weight is so important. So foremost, cardiovascular disease is the leading cause of death in women. So this pie chart is to just kind of put into perspective the fact that, 1 in 4 women in the United States dies from heart disease, as opposed to, let's say, breast cancer, which is 4%. And so if we're really thinking about the quality of life and really allowing extension of life, we can't just be focused on breast cancer. And as you can tell from this talk, we've talked a lot about nutrition and exercise and sleep, and all of those things contribute to risk of cardiovascular disease. So as you can see here, what's interesting is, I think heart disease is really emphasized in men for a very long time. And you'll see that on the left-hand side, when you look at the deaths per population, heart disease and cancer in men is quite similar. What's interesting is that I think previously, heart disease was really under-recognized in women, but you'll see that it's still certainly up there. It's kind of the lower line among the 4 there, but still clearly has an impact in terms of the total number of deaths in a young population, age 45 to 64. And certainly as a whole, cancer does cause many deaths, and that's not just looking at breast cancer, that's including colon cancer, that is including lung cancer and many other cancers. And then when we look at just the total number of deaths total, we notice that over time, the total death rate for cancer has continued to increase over time, and that the heart disease really has still, unfortunately, remained really high, although we talk a lot about lifestyle modifications, and we have numerous medications now that are meant to help reduce risk of cardiac disease, such as aspirin or statins and things like that. So these are really the focus points, I think, for health, which is, how do I reduce my risk of cancer events in the future? How do I reduce my risk of having a cardiac event, a heart attack, a stroke, or something like that? And this is just to put into perspective, because those numbers can really be really challenging to interpret. But in terms of looking at breast cancer itself and the number of deaths each year that are attributable to that of all cancers in women, it's about 15%. So this kind of just really highlights that we have to really have an open mind when we think about the various topics to focus on. So kind of just touching on that, which are the risk factors for heart disease that are known, diabetes, certainly a personal history of any type of cardiac disease or any type of non-coronary, which means non-heart atherosclerosis, which is plaque buildup, a family history of cardiac disease, and a male relative who's less than age 50 or a female relative less than age 60. If you've actually ever smoked before, had high blood pressure, or if you have a body mass index equal to or greater than 30. And unfortunately, a byproduct of aging is an increased risk of heart disease. And so there is a known relationship between menopause and cardiac disease. And there's lots of different rationale as to why that may be. Some people have suggested that it's because the estrogen and progesterone receptors are present in vascular tissue, including coronary arteries, and so that's impacted. Some of the coagulation factors are increased with menopause. There could be decreased blood flow and a lot of the vascular beds after menopause. So unfortunately, this is something to be concerned about with age. And diabetes is really quite prevalent. 1 in 4 people don't even actually know they have diabetes, but about 1 in 11 people are formally diagnosed with diabetes. And so that's 29 million people who have this. And there is an increased risk of death associated with diabetes even after a breast cancer diagnosis. So this is something that we can't neglect as well. And similar to heart disease or cardiovascular disease, there are overlapping risk factors for diabetes, as you can imagine. So age, simply being above age 45, getting older with time increases your risk. Being less physically active, specifically less than 3 times a week, a family history of diabetes, having high blood pressure, having a history of gestational diabetes, or having a higher BMI, all increase the risk of diabetes. And numerous studies have now shown that the risk of diabetes increases with age, lower estrogen, and early menopause. There are studies that have shown that hormonal therapy that we put patients on has been associated with a reduction of about 30% of new onset diabetes. And it's important to highlight that this is something we have to pay attention to, because while we have very good intentions as medical oncologists to treat breast cancer, a lot of those treatments can increase your risk of other conditions. So for instance, it is well established in the literature that radiation therapy can cause a higher risk of cardiovascular disease. Certain chemotherapies, such as anthracyclines, can increase the risk of heart failure. And even certain endocrine therapies, such as aromatase inhibitors, can increase or may increase the risk of cardiovascular disease. So we need to do a better job of offsetting the things that we're doing. In terms of diabetes and the incidence among people who are breast cancer survivors, we've noticed that that it has just continued to climb over the last decade. So almost 20 years ago, 6% of breast cancer survivors had diabetes. And when you look just 5 years ago, it's a quarter of people. And that over a period of several years of follow-up, maybe about 14% of people end up developing diabetes. Could there be other factors that contribute to that? Certainly. But in terms of the analyses that we've looked at and studies over time that are observational, it seems like there is an increased risk when individuals are on endocrine therapy, like an aromatase inhibitor or tamoxifen. However, stopping therapy is not recommended because the survival benefits of these therapies outweigh the risks. So what we really want to focus on is prevention and lifestyle modifications that reduce that risk. So there are clear strategies that have been developed that really help reduce this. And we think about lifestyle modifications foremost, that lifestyle interventions can reduce the incidence of diabetes by over half. So 58% risk reduction, which is pretty phenomenal. And those are tools that really are in your toolbox: nutrition, exercise. Other studies have also shown that metformin and certain medications can also reduce the incidence of that. That needs to be a discussion with your physician as well to determine whether or not that's the most appropriate agent for you. And if there is excess weight, then weight loss is exceptionally important. And studies have shown that for every 2 pounds of weight loss, the type 2 diabetes incidence reduces by 16%, which is quite impressive. I will highlight this case study. We have no prospective studies that show this, but we know that most women gain weight after a breast cancer diagnosis, and that weight gain could or may increase the risk of recurrence by 40%, or the weight gain may increase the risk of death by 53%. There's one study that's being conducted on Dana-Farber right now that is actually trying to determine whether or not that weight management can truly impact cancer outcomes like recurrence or death. And so this is why this is of such great interest to us. This is not meant to scare anyone. It's just meant to help you better understand the context for why we do this type of research. So I'm going to take another pause right here after the second of 3 segments and see if anybody has any questions. And if there are no questions, I will just move on to the last segment.
There is one question.
Sure.
Is BMI a good indicator of healthy weight? If you exercise and build muscle mass, your BMI will remain in the high category. Is there an alternative indicator for healthy weight?
So I love that question. It's a great question, and it overlaps with one of my research areas, which is actually tackling what we call adiposity, which is fat. So BMI it's a good measure that is broadly implemented. I can quickly get a BMI, an estimate from essentially any patient that comes in, and we know their height as well as their weight. The issue that is raised is whether or not that's truly representative of central adiposity fat. So for instance, there are numerous studies that have shown that when you do more thorough body composition studies, that you can have per individual with 2 individuals with a BMI of 24, but that their total fat mass and their total muscle mass are totally different. And there's something that, to be said of people who are metabolically healthy, although they do have a high BMI. And so I think for the average individual, yes, we use BMI. If I had all the resources in the world, of course, I would want a more detailed, objective study, like a body composition study, to determine what those proportions are in terms of percent total fat, percent total muscle mass. Some studies have shown that waist circumference can also be a better measure of what we call adiposity or fat. And so, I would say, yes, BMI can tell us a certain amount of information, but as you mentioned, let's say you're doing more exercise and you feel stronger, right? That's subjective. And perhaps your weight is or is not fluctuating, but perhaps your clothing size is changing. Perhaps there is something going on in terms of the body composition that's changing that can't be captured with BMI, which is why there are now various tools that people are trying to incorporate into routine practice, like body calipers, measuring waist circumference, using body composition studies with bioimpedance, or using DEXA scan. So there are so many things out there right now in the day-to-day practice. When we see patients, we use BMI because we can't send out all these studies for patients, and they're oftentimes not found to be able to be scaled. And so insurance companies also don't cover these studies right now. But this is a really fascinating area where I do think that we need more specific and accurate measures. And the question will be what those measures are and which specific individuals may benefit from those.
There's another question. Is it safe to take weight loss supplements while on AI?
Mm-hmm. So this is a wonderful question. So you're going to hear about me talk about this very shortly because my next session is on recommendations for weight loss, and I currently have a clinical trial that is looking at weight loss pharmacotherapy or drug that's FDA approved for individuals who are trying to lose weight, and we do enroll patients who are on aromatase inhibitors or AIs. So as of right now, there are no studies in breast cancer that have looked at weight loss supplements / FDA approved drugs in this population. And I'll talk a little bit about that momentarily.
That's all the questions for this segment.
Okay. So let's move on to recommendations for weight loss. So this is usually a very hot topic because it is certainly a struggle. And I think that part of that struggle comes from us as physicians and care team members, not necessarily providing the right tools to individuals that are trying to tackle weight. So what I thought I would do with this section is, instead of harping on just diet and exercise, which I already talked about in the first segment, I would like to just focus on some of the studies that we've done at Hopkins and also studies that we have open right now. So first, I wanted to bring to your attention that we did conduct a study at Hopkins. The principal investigator was Dr. Vered Stearns, and it was called the Power Remote Study. And we were taking a intervention that had already been trialed in a general population of people with cardiovascular risk factors and implementing it in breast cancer survivors. And there were actually a few different groups. There was a group that got in-person coaching. There was a group that got self-directed care. And we really wanted to see if the remote coaching and the in-person coaching yielded any different outcomes in terms of success in weight loss. What was unique to this intervention is that there was a formalized coach, whether it was in person or quote unquote virtual or remote, that was routinely calling patients weekly for the first 3 months, followed by monthly, months 4 through 12. For dietary recommendations, just reduce calorie diet based off of high veggies, fruit diet based on the DASH diet. And we did use a tech platform called Energy at that time. And so this was really the crux of this type of weight loss strategy. And what we found is that at 6 months time, that about almost half, about 46% of individuals were able to attain 5% weight loss in the group that actually received the Power Remote intervention, as opposed to only 10% if they do self-directed weight loss approaches. And if you look at 12 months time point right here, you'll see that the numbers somewhat lower, which we can often see after people have been followed out for a year, is that number is about a third. So about a third of patients who are on this type of coaching program are able to have 5% weight loss at 12 months. And when we try to really look at a higher threshold, some people would say, well, maybe 10% is really the number that we should be focusing on. We looked at 6 months time, about 1 in 5 women actually were able to lose 10% at that mark. And that when we even look out further at 1 year, 1 in 4, so up to 26% had actually lost at least 10% of their weight as compared to a self-directed approach. So what we learned from this is that using this type of intervention, which is really routine coaching and remote platforms, we can really help women to achieve this goal. And it doesn't help all women, but it helps a good chunk of women. And so the next question that we thought about was, well, what are other factors that may influence weight strategies that need to be addressed to allow a greater number of individuals to be successful in weight loss, right? So some people would say, well, I'm trying this lifestyle intervention. I'm modifying my diet. I'm doing a lot more exercise, but I'm stuck, or maybe I'm not achieving the type of results that I want to achieve. And so we thought about other factors like sleep that can really impact weight. And so this is a study that we just finished enrolling for right before COVID happened. And it was called the COIN study. The principal investigator is Dr. Janelle Coughlin. The title of the study is Cancer, Obesity, Overweight, and Insomnia Study. And in this particular study, just brought on about 30 patients, and these women all had early stage breast cancer and a BMI of greater than 25, but they had to have a formal diagnosis of insomnia, not I'm struggling with sleep, I can't wake up, but literally had to come in for formal sleep evaluation, have an actigraphy, et cetera, and have this diagnosis. And then were randomized to either get this sleep education, which is technically a placebo, or this cognitive behavioral intervention for the treatment of insomnia. And that was done prior to the lifestyle intervention that you just heard about in the previous study. So when we looked at some of our data from this, we do see some exciting results. We hope to be able to share more information perhaps in the next year. Now, I will highlight that there is some research that we've done from the prior study that Dr. Stearns headed that suggests that sleep is important. And so I'll just share this with you. It is unpublished in manuscript form, but we did present it at a conference recently. And this looked at weight loss percentage by baseline sleep score and intervention. And what we found that was really interesting is that if you look at the people who had poor sleep, that's the left-hand side, you basically complete a survey and you get a T-score. And the higher the T-score, the worse your sleep is. And in individuals who had poor sleep and went through a power remote intervention, that exact same intervention I told you that was with the coaching and all the lifestyle modifications, the average amount of weight loss was about 4.06%. That was from baseline to 6 months. But you'll see that when we look at the group that actually had better sleep, that means a T-score below 55, the lower the better. The people who went through the same exact intervention but had better sleep actually lost more weight. That was a loss of 6.77% at 6 months. And you'll see that at 12 months, an additional 6 months later, that discrepancy is still seen. So that's a weight loss of minus 3.8% and a weight loss of 7.54%. So this really raises the question that, there are other components that are really important to figuring out a weight loss strategy that's effective. So as I said, we are excited to share the study from this COIN study, probably will be about a year from now, but it's going to help us to find better studies and approaches to helping people tackle weight. And this is just a summary slide of everything I just said. And this is a study that I briefly had mentioned in the previous section where I said, why is weight important and does weight loss impact outcomes? This is a study being done at a Dana-Farber. It's called the Be Well study, the breast cancer weight loss study. It has over 3,000 participants, all with actually slightly more advanced breast cancer. They usually were diagnosed initially with stage 2 or 3 breast cancer and have a BMI of at least 27. And they've been randomized to an intervention, which is just kind of health education, which you consider a placebo, and a telephone-based weight loss intervention. And the primary goal of this 2-year study, of this 2-year intervention, is to see whether or not this intervention, this approach, impacts disease-free survival. So this will be our first prospective study that looks at this. So it's really exciting. Will take a little bit of time, I think, for us to have some results, but just a really terrific study that's going to answer this particular question. And now I'm just going to briefly talk about my study that's open here at Hopkins. It's called the AMU study. It's called an Adaptive Nutrition and Exercise Weight Loss Study. We are currently open. We plan to have a total of 55 participants. We have put on 18 participants thus far. This is for individuals who have early stage breast cancer. That could be stage 0 to 3, who have at least a BMI of at least 27 with obesity-related comorbidities or BMI of greater than 30, and who are not taking tamoxifen. And so they can be on aromatase inhibitors. In this particular study, everyone gets the behavioral intervention, that power remote intervention I was talking about with the coaching that's remote, with those lifestyle modifications and kind of a personalized plan is a constant for every individual. They also receive a Fitbit Charge 3 and a learning curriculum. And they get those weekly contacts the first 3 months and monthly contacts the last 3 months. Research has shown that how quickly you lose weight is important. While you've probably heard slow and steady wins the race, that is not true for weight loss. Numerous studies have now shown that. And so what we've done in this study is we've identified a weight loss threshold that has been shown to correlate with sustainable long-term weight loss at 1 year and several years later. And so we've chosen a threshold of about 5% after 8 weeks of lifestyle intervention. And if individuals have attained that weight loss at that mark, they continue on that lifestyle approach alone. So they keep chugging along. But if they have not achieved that, then we do add a FDA-approved pharmacotherapy medication called Contrave. This has been approved since, I believe, 2014, has had extensive post-marketing studies, and that is augmented on top of that behavioral weight loss intervention with our coach. And so really the goal of this study is to assess the proportion of individuals who can attain at least 5% weight loss with the addition of this to the behavioral weight loss intervention. If you are interested in this study, please email amy@jhmi.edu. It requires 3 in-person visits at baseline, at 2 months, and at the end of study, which is 6 months. Everything else is remote. If you are a Hopkins patient already, it's quite easy to get you pre-screened and evaluated for the study. And if you are not a Hopkins patient, we are glad to pre-screen you and determine whether or not you'd be eligible. Additionally, there are other programs that really help to focus on healthful eating and activity that are not through necessarily a clinical trial, but go through our internal medicine physicians here. And so I provided a website as well as a phone number here. If you'd like to review my clinical trial some more, there's a link for that as well. And I will just say that as a physician at Hopkins, we are truly committed to research and delivering the best possible care. We have numerous sites, whether it is in Baltimore City or closer to Washington, D.C., and that really we work as a team to take care of you. And that's not just the oncology team, the medical oncologists, the surgeons, the radiation oncologists, but it includes primary care as well. So I will just close with two last slides that just basically sum up everything I talked about during this webinar. But foremost, that our recommendations are pretty simple, and you've probably heard them before, but it's easier said than done. So we emphasize avoiding smoking, controlling vascular risk factors like blood pressure, high cholesterol, diabetes, eating a balanced diet, such as a Mediterranean diet that's really rich in vegetables and fruits and lean protein, and particularly protein sources that have omega-3 fatty acids. Being physically and socially active, including aerobic activity, taking care of your mental health, and using your thinking and cognitive skills like your memory skills. This is a visual of what I just said. I liked this. This is created by one of the cardiologists here. It's kind of easy to remember the ABCDE of this, and some of the things that the cardiologists in particular will look at, but many of our primary care physicians can also address quite a few of these. And I will just, the last thing I will say is, even though I am an oncologist, I work very closely with primary care, at least the primary physicians that are here at Hopkins, and we've known that after breast cancer treatment, it can be extremely challenging to get patients back to see their primary care doctor. So if I could urge you to do something, it would be to make sure that you don't lose touch with that provider. During the past year and a half, during the pandemic, it's been really challenging to get really any patients to see their primary care doctor. And sometimes that's because of the clinic itself and the policies they have. But numerous individuals report avoiding medical care because of those concerns. But I will say that if you are concerned about your cardiac health, you're trying to focus on diabetes prevention, you are having issues with sleep, you don't have to just talk to your oncologist about it. I would urge you to talk to your primary care doctor about it. So That is really the end of the webinar today, and I'm happy to take any other questions that you guys may have.
Dr. Shen, would you mind just putting my video back on as the host?
Absolutely. Can you give me 1 second while I
No problem.
that? Okay. Alrighty.
While you're doing that, I'll read the next question from our group. What is the DASH diet?
That's a good question. I think I might have mentioned that so quickly in my talk and I hadn't gone on to expand on it. So the DASH diet is actually a diet that was established in a group in which we were trying to tackle high blood pressure. So it stands for Dietary Approaches to Stop Hypertension. And while the intent of that was to find a diet that would lower blood pressure, we found that it can actually be overall quite beneficial to individuals who are tackling other things as well. So reduction of heart disease in particular. The study showed that if you do a standard DASH diet, so that's like vegetables, fruits, low-fat dairy, and some whole grains, fish, like the healthy proteins that we've already talked about, using that standard diet, that there can be significant drops in blood pressure, which are great because high blood pressure can contribute to increased risk of heart disease and stroke as well. So a lot of times we'll talk about the DASH diet and a focus on reducing the amount of sodium that individuals consume a day. Typically, you know, I tell most people like 2 grams a day is really like the upper cusp of what you should be taking in. There are people who have a more strict sodium intake and they do a gram or a gram and a half. But I think it's wise to do that. I think ultimately, we don't necessarily push people to do the DASH diet, but we do incorporate components really focused on, as mentioned, you know, a more heavily plant-based diet that's high in fruits and vegetables and grains and things like that. And if an individual has certain risk factors for cardiac disease, then I think adhering to a DASH diet where there's sodium restriction is actually quite beneficial.
Are there any more questions from our audience? No? Well, I'll speak to you from behind our logo. I just would like to say that I feel, you know, validated that our iRise Above program, the 12-week online wellness training program, which Jared Stearns, who is on our board of directors, is, you know, she's been so supportive of what we do, from the perspective of, you know, the remote coaching program and the intervention. She's been very instrumental in supporting that. And I encourage all women in the audience who would like to learn more information about how you can get involved to join us. We have a lot of fun. So once this webinar wraps up, I'll share a video link and the presentation that you've just watched, and some information about the wellness program in case any of you want to join us for the next session. Currently, we're in 8th week of the 12 weeks now, and there's a number of women in the program I see in the audience who are, you know, part of this program or former programs. So I'll send that out, and hopefully we'll be able to get some new participants for sure, and retain some of our old ones. So thank you very, very much. Unless there's any more questions from the audience. Going once, going twice. I thank you so much for taking time out of your day, Dr. Shen, to talk to our group. This is some very informative information, and I really appreciate you sharing.
Absolutely. Thanks for the invitation.
All right. Thank you so much.
Bye, everyone.
Have a lovely day.